Good morning. This is a weekly case discussion from EndoTODAY. I'd like to show you a typical case of gastric adenoma in a patient with autoimmune gastritis. Autoimmune gastritis is a recently recognized, quite important, but almost neglected disease in Korea. It's an immune-mediated disease that targets the parietal cells of the gastric body. It is more common in Western population, while its prevalence in the general population is estimated to be between 0.1 to 2%. I think it is also the same in Korea. It is well known that neuroendocrine tumor is the most common neoplasm in patients with autoimmune gastritis. In addition, gastric adenocarcinoma can develop. And I guess autoimmune gastritis is also a risk factor for gastric adenoma, which is a very important precancerous lesion. We evaluated the incidence of autoimmune gastritis in Korean patients with gastric cancers. Anti-parietal cell antibody was tested in 612 consecutive patients with gastric cancer. Among them, 5.5% tested positive for anti-parietal cell antibody. For the further discussion, I recommend to read the article published in February issue of Gut and Liver this year. In Asia, the incidence of Helicobacter pylori infection and gastric cancer are high, but their association with autoimmune gastritis is unclear. This is a representative image from gastric cancer with autoimmune gastritis and Helicobacter pylori infection. The relative role of autoimmune gastritis and Helicobacter pylori infection is not clear. From now on, I'd like to show you a typical case of gastric adenoma in a patient with autoimmune gastritis. A 53 years old lady was referred for the management of adenoma with low-grade dysplasia at the mid to high body posterior wall. It was about 5 mm sized, pale, flat elevated lesion. I reviewed the other endoscopic images and found that the antral mucosa was quite normal, but the oxyntic mucosa was very atrophic. This is a typical finding of advanced autoimmune gastritis. We call it reverse atrophy. I ordered some blood tests based on endoscopic findings. The result was very typical of autoimmune gastritis. Anti-parietal cell antibody was positive, but anti-intrinsic factor antibody was negative. Pepsinogen 1 and 2 level was low, and pepsinogen 1-2 ratio was very low, less than 1, 0.7. Gastrin was elevated more than 6 times of the upper normal limit. Helicobacter serology was negative. Hemoglobin and TSH was normal, but free T4 was slightly decreased. This is a review of outside pathology. It was a tubular adenoma with low-grade dysplasia. Using APC, argon plasma coagulation, ablation treatment was done for the adenomatous lesion. And I observed the whole stomach very carefully. Antrum looked normal, but the body was very atrophic. However, there was no focal lesions suggesting neuroendocrine tumors. Biopsies was done from the atrophic body and normal-looking antrum. Gastric body mucosa was very atrophic with some mononuclear cell infiltrations. I cannot see the oxyntic gland with parietal cells. Oxyntic gland, they just disappeared. And there were some areas of intestinal metaplasia with scattered goblet cells. In the close-up, neuroendocrine hyperplasia was clearly observed. Another piece of gastric body, the same finding. This is the enteral mucosa without atrophy, without intestinal metaplasia, and without Helicobacter pylori. Just normal. Today's message is that autoimmune gastritis is one of the risk factors for gastric adenoma in Korea. Thank you very much.